Hey guys, this is Mike and Ed. We're going to go ahead and we're not going to start here, but just get this feed started here about 5 minutes early just so that people can log on and get all the technical issues straightened out that you may have. And I think we got them figured out on our end. We're already getting hellos here. We'll wave back at people. There's a little wave button we can wave. I wave to my daughter. My daughter's watching. Hey, Mike. Again, we're going to go through some of the things we did last time. I'm sorry to kind of repeat a few things, but I just want to really hit a few points home. We got some great questions from last time. You can see Ed and I look a little different today than we did last week. As a result of one of those questions, we tried to talk ourselves out of it and just couldn't do it.
You know, I think it's a good point that you don't
help them out with what the difference is, Ed.
So we're both wearing surgical masks, which is going to keep us from spewing anything into the air that might infect one another. I think in the last week or 10 days, the whole country's kind of gone from thinking these aren't really needed to really realizing that they do stop the spread, and it's probably not a bad idea because we don't know who all's infected with corona or could be spreading it unwittingly, not even thinking you're sick. And so Mike and I work together, so we're kind of in close quarters there, and even at the hospital we're wearing the masks a lot more, even in the public areas and hallways.
Yeah, as of a couple weeks ago, none of the physicians, nobody was wearing masks actually inside the hospital, and it was kind of interesting. There were the physicians, I think, were the first to start wearing them, and then it's kind of some people were told not to at certain hospitals because you're scaring the patients and so on. And I think we're kind of all over that at this. We're all kind of over that at this point and kind of realize that we just need to protect each other. So as a reminder, it's kind of interesting because Ed's mask is not protecting him and my mask is not protecting me. It's kind of Ed's mask is protecting me and my mask is protecting Ed. And if I wanted to be protected because I was concerned that there was a lot of COVID, say, in the room, I'd be wearing this N95 mask, which is, if you wear it, these are a lot less comfortable. They're hard to wear for a whole shift.
They filter out a lot more of the virus or bacteria that could be in the air, and so if there's virus in the air and I'm breathing in, I'm much less likely to catch it. This will catch about 95% of all particles, but it also functions as a surgical mask as well and protects Ed from me. So anyway, I'll put this back on because it's much more comfortable and I can wear this for a whole shift here. Got a couple minutes to go here. Believe it or not, Dr. Malcom here, who's an Army Ranger, had not heard of Captain Crozier's firing. We might get into that briefly and kind of get his thoughts on that. Are you still an Army Ranger? I mean, if you're like an Army Ranger, you like always a Ranger? Or always.
You always are?
Right.
Wow.
Well, I mean,
so I got to be careful. I feel very safe now.
Not active. But. So, and do keep the questions coming. That really lets us know what y'all want to hear.
Yeah, so there's a way that you can do questions from your end, and we'll kind of jot some of those down. We got some loaded up from last week, too, that we want to hit. So, looks like we're almost there. I got about another minute. I've got a number of people who are kind of logging on. I want to make sure we kind of are timely here. Les, our police officer. Hey, Les. Good to see you. Up to 294 deaths in Georgia.
Wow.
All right, I see 7 o'clock, so kind of in the interest of time, I'll turn this around again and we'll kind of shoot through. This may take about 30, 35 minutes-ish, and I'll try and go through this a little faster than last time. just because y'all have seen some of these before, but just kind of, again, want to kind of remind everybody kind of some of the highlights. So here we go. COVID-19, let's work together and stay apart. This is Dr. Lipscomb and Dr. Malcom. It's April 6th. Just as a quick reminder, we don't represent any physician group. We don't represent any hospital. We do work for a physician group in a hospital, but we don't represent them. These are simply thoughts of ours being frontline on the COVID front. And just with a number of conference calls we've been on and just reading and talking to our colleagues across the country, this is kind of an assimilation of what we feel are kind of important details that people need to know about COVID. So without further ado, COVID-19. Again, COVID-19, coronavirus disease, 2019, that's where the name comes from, COVID-19, also known as a severe acute respiratory syndrome, coronavirus 2, SARS, coronavirus 2, the coronavirus 1 was in 2002, also started in Wuhan, or in China, believed it came from bats. The first virus was much more deadly in terms of percentage of people that died. But a much quicker virus in terms of its activity. This one's now been going on for about 4 months here. First case in the United States was in Washington State, January 20th, and the first death was February 29th of 2020. Again, the coronavirus is a virus. The picture of the coronavirus is to the right. There are a number of other viruses to the left, HIV, hepatitis, Ebola, are all viruses, and you can see they all look a little bit different. They all infect different parts of the body. The HIV virus, as we know, affects the immune system. Ebola virus primarily affected the blood. And the coronavirus, as you can see, looks very much like the influenza virus, and these are respiratory viruses attacking the respiratory system. We believe, or we know, that the coronavirus lives in the bat population. We know that viruses are essentially inert things. They can't move. They cannot make energy. They are completely dependent upon a host organism to be able to reproduce and basically stay alive. If all the host of all the bats in the world and people in the world were not here, then coronavirus may very well die off because there would not be a reservoir for the coronavirus to live. We believe the bats, that there's an intermediary, and there's a lot of evidence now to suggest that the pangolin, which is a rare mammal in China, may have been the intermediary. These pangolins are sold at markets much like this in Wuhan, China, and we know that when we get bats, an intermediary, and people together in close proximity, there's a chance that this virus that lives in bats can jump to this mammal, which can then jump to humans. It happened in 2002, and we know it happened in 2012 with camels in the Middle East. This is a blow-up of a alveolar cell. This is one, or alveolar air sac, I should say, which is the little air sacs that live in our lung. We have thousands, if not hundreds of thousands of these in our lungs. And what the coronavirus does, this is the MERS virus, but the COVID coronavirus acts in a very similar manner, attacks the air sacs of the lung. The lungs start to fill up with fluid in people that get very, very ill, and we have no more air exchange, and so we may not make it. This is a normal chest x-ray over here. This is a chest x-ray of somebody who has coronavirus, and you can see kind of all this white stuff out here. The lungs should be like this. It should be all dark, and oxygen can get down into the lungs and be healthy. Here, this lung is filling up with fluid, and in kind of a severe case over here, it can look as bad as this. This patient actually has a breathing tube down. You can't actually see the tube, but there's a little stripe that comes on every tube, and we know this person's now on a ventilator. And once a patient is on a ventilator, their chance of dying is about 50 to 60% with coronavirus. So we want to try to avoid people getting to that stage right there. Remember the difference between a virus and a bacteria. Bacteria can be killed with antibiotics. It says here easily. We'll kind of debate that in a different talk on another time. But antiviral drugs can only slow down reproduction of the virus. It cannot actually destroy the virus. And in general, antiviral drugs do not work nearly as well as antibiotics do for bacteria. What are the symptoms? We know the symptoms: fever, cough, shortness of breath, similar to many other viruses, including influenza. So it's very difficult when somebody comes in with these symptoms. Even now, I mean, even when there's coronavirus kind of in the community, somebody comes in with these symptoms, we still don't know, because of lack of rapid testing for COVID, to know, is this person with all these symptoms actually have coronavirus? The characteristics of coronavirus, we talked about last time. The incubation period is about 5 days, so you can have it for about 5 days before symptoms show up. Virus lives on surfaces as long as 3 to 4 days, and as of about a week or two, we thought that this was, and it still is the primary mechanism by which people catch it. Somebody coughs on a surface, we touch it, and then we get our hands near our face, and we have now caught that coronavirus. We did not think that there was much aerosolization of the coronavirus, but we are now starting to question this, and maybe coronavirus is shed in, is aerosolized, and I'm going to get to that in a little bit. There are case reports of asymptomatic people transmitting the infection, and now that has been fairly certain. There's actually studies from Nature as well as other leading journals that coronavirus is shed early in infection. So you can catch it. People are walking around. They may have a little sneeze or a little cough, but essentially asymptomatic, and they're shedding the infection. We know that the death rates get very high when people are older. So this is, young people, 0 to 9. As we get up, this is people over 80. The death rate, and this is from different countries. This is Italy, China, South Korea. These are the death rates, very high. But even at young ages, we see that even people in their 30s or 40s, the death rate, 0.3%, 0.2%, 0.1% in South Korea. These are higher than the normal flu death rates. So even though you're young, you are not fully protected. And we're seeing people die at young ages. We've seen some in their 30s, in this area, die of coronavirus. Lessons from the Princess Diamond ship. This was the first cruise ship where there was a large outbreak of coronavirus. It set sail in late January and was quarantined February 3rd or 4th off the coast of Japan, when they found a number of people on the ship had the coronavirus. What did we learn? 19% of the passengers tested positive for the virus. 46% at the time of testing had no symptoms, yet they had the virus. So 46% of people with no symptoms aboard this ship could have spread the virus without showing any symptoms themselves. 18% of this total number went on to exhibit no symptoms at any time. So they were just asymptomatic carriers that never developed a cough or any symptoms of coronavirus. There were 11 total deaths for a 1.5% death rate. All of these folks were over 70, with the exception of one where I couldn't find that last person's age. So despite the criticisms of the quarantine, isolating people made a difference. We know that it made a difference. And why is that? Because when they quarantined everybody on the 3rd of February, they estimated one person was infecting 7 others. But after the quarantine, it went down to less than 1. And this is the point I already made: high occurrence of carriers who are asymptomatic or minimal symptoms. So the slide I showed last time, which was on March, last week, 7 days ago, showed kind of the progression of this disease, and this is worldwide. March 10th, we had 114 reported cases worldwide. It went up to 652, and now we're over 1 million cases as of yesterday. So a factor of 10, cases multiplied by 10 in less than a month. The total deaths around the world went from 4,000, we're up to 69,000. I'm sure we're over 70,000 today. In the United States, this is what it looked like back on March 3rd. We had 124 infections, 9 fatalities. And mind you, we're at the 6th today. This is just over a month ago. And we now look like this. This is from the 30th. We had 30th of March. This is 6 days ago. Had 143,000 cases. On the 5th, that was yesterday, we had almost, about 2.5 times the number of cases. The deaths have gone from 2,000 to 9,000. And as of this morning, it was reported we had more than 10,000 deaths in the United States. And this is a scale to kind of show you how fast this is increasing still in our country. We're over 300,000 cases. So let's look at things a little bit differently. How's the United States doing compared to everybody else? Now, this is a number of cases reported since the first 100th case. So once you have 100 cases in your country, the case count starts. And so how the United States, we're about 28 days in from the 100th case. United States is increasing more rapidly than any other country. United Kingdom down here, Iran, France, Germany, and so on. Now, some of this may have to do with reporting. Other countries certainly may not be reporting it as much as we are, but there's certainly a feeling that things are spreading faster in the United States than they are in other countries. This is kind of the hot spots around the country. This is total deaths reported by county. We all know that New York is a real bad spot. And last week, we know that New Orleans is a real bad spot too. But look at Atlanta. Atlanta's had quite a few. Detroit, this is kind of the next up-and-coming hot spot. Chicago, hot spot, a few in Denver. And then we have California and, of course, Seattle. And leaving out Miami down here, there's quite a few cases around the Miami area as well. This is across the United States. This is an estimate of where we are going. A little bit of good news today, actually. Back on March 28th, the estimate was 81,000 deaths in the United States. 4 days ago, on April 2nd, it was upwardly projected to be 93,000. But just today, kind of an estimate that maybe it's going back down, that downward estimate is going down to 81,000. So looking a little bit better. And this data is from the Institute for Health Metrics and Evaluation. This is a very reputable source. It's from Bill and Melinda Gates' foundation. It's a not-for-profit. It's a very reputable source of kind of targeting where we're going. This is another look at confirmed cases by metro area. We know that New York is kind of on top with the most number of cases. But look at the other ones. There's Detroit is rapidly catching up. Probably won't quite catch New York City. New Orleans we know about. And then look at Atlanta. Cases in Atlanta are kind of heading the way of New York and New Orleans. Again, not quite there. Interestingly, Seattle, which is kind of always known or thought to be a bad area, we're kind of outpacing Seattle. Deaths by metro area, New York is way up here. We have Detroit is catching up. We have New Orleans and Chicago. Atlanta is way down here. We're actually doing pretty good so far as deaths in Atlanta. And part of that is probably that we've not overwhelmed our system yet here with cases, and hopefully it stays that way. Again, deaths by metro area. This is the same graph that I just showed. But if you look at deaths per 1,000, you kind of see that the places that are over, so this is the number of deaths per a similar number of people, per 1,000 people, that the highest death rates are in New Orleans and New York City, kind of the places that are overwhelmed. So kind of like when you hit this breaking point, it starts becoming very difficult to take care of people. And the numbers for deaths per 1,000 get very high. Detroit is kind of catching up. And we actually haven't, we are down here. Atlanta's actually down here somewhere. It's just not lighting up on this slide.
Kind of between Seattle and Los Angeles.
Yeah, we're kind of down there. So this is how things are going in Georgia. The number of cases are still increasing. They're doubling every 4 to 6 days. Our total deaths in Georgia, 210 right now. So, hopefully these cases stay low. We're doing actually pretty good right now in Georgia, kind of holding our own. This is kind of the target where we're going in Georgia. And see, last week we were kind of like here, but we're up here now. So far as the projections are kind of a few days behind, of course. And we're looking to peak. Kind of the worst of this is going to happen probably late April, probably 3 weeks from now. And they're looking at, I think the next slide shows it. Yeah, this is deaths in Georgia, predicted to be 3,200 4 days ago. We're up to 3,400, kind of prediction as of this. This was as of this morning. And this is kind of the spread. They're kind of looking at 5,000 on the high side, 2,500 on the low side. So again, kind of go through what we should do for coronavirus before you have it. Immunization is a possibility. I'm going to talk about that in just a second. But really, there's no immunizations right now for coronavirus. So the best we can do is to stay away from it. And after you have it, immune system, rest, stay at home. But if you need supportive care, if you need to be at a hospital, you need to go to the hospital. And that is about all we have. There are some medication treatments out there that I'm going to talk about in a second. But nothing has been proven. I mean, we hear about hydroxychloroquine and these life-saving drugs, and I'm going to kind of talk about that in a second, that we really shouldn't be hanging our hat on that right now. So prevention, what is number one? Social distancing is the term that we hear. And I want to, my video feed kind of clipped out last time, so I didn't really get to make this point very well. But is it really social distancing or physical distancing? And I think here, I don't like mincing words sometimes, but here the words are very, very important. Social distancing means cutting off contact from other people. And right now, this is not the time to be cutting off contact with other people. We have, I don't know, we have 1,000 people on this feed right now. We are not cutting off contact with people, but we are physically distancing. This is my niece, Ruby. She's 5 years old. She has a birth defect that's left her with an oropharyngeal problem where she's had multiple surgeries. She would be a very, very bad person right now to catch COVID. This is my father. He's 78 years old. He's had heart surgery. And this is my stepmother, Denise. She's had multiple throat operations herself, really for a different issue. All three of them are very, very high risk for catching COVID. Yet they're more than 6 feet apart here. They're being very careful. And they are physically distancing. They are not socially distant.
Do you want to take a question on this right now?
I'll tell you, why don't you write that question down and we'll get to it.
Okay.
Okay. Okay, so let me just remind you of the Spanish flu, the tale of two cities, one city that did well and one city that did not do well. Philadelphia threw this parade in the middle of the flu epidemic. And what happened? 16,000 people in Philadelphia wound up dying as a result of this parade. Worse than any terrorist attack that's ever happened at any large gathering. St. Louis, on the other hand, shut the city down. They had a parade. They canceled the parade. They also canceled school and libraries and all the things that we're right now doing in multiple cities across the United States. And what were the results? This is the death rate per day in Philadelphia. And this is the death rate per day in St. Louis. Much more handleable, if that's a word, by the medical system. This spike in cases where Philadelphia could not handle the number of cases that came into their hospitals likely resulted in a much worse death rate than otherwise would have happened. So the 50% lower death rate in St. Louis and Philadelphia, and again, this term we know of is flattening the curve. So what was going on in Mardi Gras in New Orleans? Well, it was Mardi Gras. And to back up, there's two places that are not doing well right now. One is New Orleans and one is New York. New Orleans, it is because this was what was going on in February 2020, less than 2 months ago. Today, the governor said that he could run out of ventilators as soon as 3 days from now, and the ICU beds 2 days after that. When back in March 27th, they had 65 deaths, 1,800 positive cases. A week later, they're now up to 161 deaths, and you saw the graph on the previous page how these are still increasing in New Orleans. So gatherings like this, very, very bad when coronavirus is out there. This is New York. This is Madison Square Garden in late February, full of people spreading coronavirus. Today, it's going to be the hardest and saddest week of most Americans' lives. It says Surgeon General Jerome Adams, and he's specifically referring to how hard hit the New York hospitals are. This is a slide that shows kind of how physical distancing works, and I showed this last time, but this is New York, this is New Orleans during Mardi Gras, and these are all people getting infected, and this is how fast it can happen. And this is the graph of the number of people infected with coronavirus. So the pink, either the people did not make it or they're now over it, over their illness, so they've either made it or not, but they can't be infected anymore. And the idea of flattening the curve is that we got to keep that bump. We can't let this happen. We can only let this number of people, right about here, get infected, because once we go beyond that, our ability to effectively take care of people goes away. This is what happens. I need to go to the next slide. This is what happens when we socially distance or physically distance ourselves, when we don't let people come into contact with each other. And it's a very simple visual thing, but it's something we all got to keep in mind. We need to not be contacting each other. Now, there's an excellent similar presentation to this. I actually have it uploaded on my Facebook page. It actually goes into a lot of permutations of this, where let's just say all of these people came into a common area like a supermarket or the hardware store. We have to be very, very diligent in those places, because as it shows, these are places that can spread virus very, very quickly if we're not very attuned to what we're doing. We got to pay very close attention to our hygiene, where our hands are at, and what we're doing in these places. And now there's actually a lot of thought that we should all be wearing masks in these places. So physical distancing, this cannot be overstated enough. We are doing a great job. When we all drive around a little bit, and we all see that there's really there are people walking around outside. They're all 6 feet apart. People are not congregating in certain places. They're not congregating at the parks and so on like they were. So we're doing a great job. And right now, with us being on the kind of that steep part of the curve, we need to be extra diligent that we don't let our guard down right now.
I do want to just, one of the questions was just, what's the end game with social distancing or physical distancing? Is it just to keep the health system from being overwhelmed? And hopefully that slide showed it's not just for the health system, that this disease will run its course and do less damage if we physically distance ourselves. I think that's just an important point that people might not understand.
And I think let's come back to that at the end too, because people are wondering, well, what's the end game? We're just going to stay in our houses and then we all come out. It's just going to spread again.
Yes,
but we have some comments about that we will get to at the end. All right. So in addition to social distancing, obviously avoiding coughs and sneezes, and we need to be staying 6 feet away from people. Because we know that being within 6 feet, there's something about either people breathing the air, that there's probably some droplets that are coming out in people's breaths. Or if you're 6 feet away and someone coughs, you just can't get out of the way quick enough. And please forgive me for this demonstration here, but this is the difference between droplets and aerosol. People kind of confuse the two, don't really understand it, and I apologize. I know this kind of looks a little gross, but this is actually going to show you what droplet spread is. This is a guy sneezing, and these that are coming out of his mouth, these are all droplets. This is not aerosol. There's a bunch of virus on all of these particles if this guy had COVID, and they're just spraying, and looky here, there's about 2 feet right here. Things are landing maybe about 2 to 3 feet away from him. That is what droplet spread is. And all these droplets are just going to be, on the handle of the grocery cart. They're going to be on the door handles to the grocery store. That's where these things are going to land, and they're going to sit waiting for you to touch them. And when you touch them and get these droplets near your face, that's how you're going to get the virus. Now, in the last week, there's a lot of thought that perhaps, I don't know why this is running back twice. There's a lot of thought that perhaps it may be at least some of a aerosolized spread. And what this is, and we don't really know the significance of this. This is about 7 to 8 meters that this guy just sneezed. That's about 25 feet. So there are virus particles that can become aerosolized or suspended in the air when somebody sneezes. Now, how long that's out there and how many viral particles is it, we don't really know. But there's starting to be more attention paid to this. So the point to you and me when we go to the grocery store is we've got to really be careful. If we're just away from other people and they sneezed, 20 seconds ago, we don't want to be walking into that cloud you just saw. And again, this is, guys, doing it all twice here. So this is kind of what that jet looks like. And again, this jet, and with a bunch of suspended viral particles, you just don't want to be walking through that within, several minutes of somebody having done this. Okay, so airborne may be transmissible by normal breathing. And so now, and this comes from the New England Journal of Medicine, that we may want to have everybody wear face mask, or even covering your face with cloth when you're walking around the grocery store. What does this say? This says that viral RNA particles are detected in 40% of aerosol, that's sneezing, and 30% of respiratory droplets, that's like when someone coughs, collected from participants without a face mask. So if someone has a swab that's kind of sitting, several feet in front of someone and they sneeze or cough, 40% of people that do not have a mask on, that coronavirus or the viral RNA from coronavirus can be detected. However, if people are wearing a mask, if I am wearing a mask, none of that gets out either in sneezing or coughing. And that is the benefit to everybody if we all are wearing a mask. Okay, avoid touching handles, common surfaces. I showed this slide last time. I just got to remind everybody. I see this all the time. I've been to the grocery store, I've been to the hardware store, and people pull their cart out and just start pushing the cart. You have to think that this cart has coronavirus sitting on it right here. Door handles, especially think about bathroom handles. We have to get into the bathroom. You just got to be careful not to do this. Maybe open it with your elbow. As soon as you touch the door handle, think about wiping your hands off or cleaning your hands in the sink with soap and water as soon as you get in there. My favorite from the airport, I don't think any of us are flying, but people touching these handles. And of course, when your neighbor's dog comes up to you and they're looking cute, just realize that that dog has been in that person's house or around your neighbor. It's just kind of something to think about. Clean hands regularly. I'll remind everybody again, alcohol-based sanitizer has to be 60% alcohol, like Purell. And when you wash your hands with soap and water, do it for at least 20 seconds. And be sure when you're washing your hands, I'm going to show you, I know I have at least one surgeon watching here, so he's going to laugh at me, but you want to get between your fingers real good, and you want to get the backside, and you want to get the other backside right here, and you want to be doing that for at least 20 seconds. All right, individual tested for COVID-19. We went over this last time again. There's little utility in individual testing. Why? Because the test is 60 to 70% accurate, and it does not change your treatment. Also, we still have limited testing. One of our frustrations is limited testing. Hospitals only testing admitted patients. Testing centers even had limited number of kits. And again, I told you last week that this may change, and I don't think we've really seen much of a budge so far in the ability to test. So, conclusion, don't go to the ER or to your doctor for testing alone, but absolutely, remember, you go if you're having breathing trouble or chest pain, or you're having something you would otherwise go to the hospital with. I think there's a big worry amongst doctors that there are people who have other illnesses like asthma or something, and they're scared to go to the hospital because they think they may catch COVID. And I think that's a very real concern. But at the same time, we've seen people with ruptured appendicitis. We've seen people that kind of have conditions where they should have been in the ER and have maybe waited a little bit too long. And I'm not talking about conditions related to COVID. I'm talking about appendicitis or people with heart trouble that need to be seen. So please don't think that ERs are being overrun right now with COVID, at least not in our area in Atlanta. If you need to go to the hospital, you go to the hospital. Here is a reminder of a placard that was put up at one of the hospitals, indicating just what I said. COVID-19 testing does not change the treatment. You need to stay at home and isolate. If you're sick, you should call for advice and then seek care. If you otherwise would go to the ER for care, chest pain, shortness of breath, altered mental status, feeling extremely lightheaded, dehydrated, these sort of things. All right, so treatments. Where are we at right now? Vaccines. Okay, how does a vaccine work? Now, ultimately, we think that vaccines are going to be the solution to this problem in years to come. But they're not going to happen this cycle. How do vaccines work? Well, this is kind of a cartoon of some attenuated viruses. This is virus. This might be a coronavirus right here that's been inactivated. So it's killed or knocked down in some way. And this is injected into people because this virus here cannot hurt us. These are antibodies here. Your body, once they see this, starts making antibodies. Your body actually will start making antibodies if this virus was not killed, but was an alive virus. You would also make these, but the problem is the virus would be able to replicate at a much more rapid rate. What you do is you give an inactivated virus to somebody such that the body can make lots and lots of antibody, such that if it ever sees a live virus, this can happen, is that the antibody covers the virus, so the virus essentially becomes inactivated and cannot hurt you. And the body is very, very smart. It can remember these antibodies for a long period of time. So it may just shut down and maybe make a couple antibodies, or has these things called memory cells, such that if it ever sees this virus again, it can very, very quickly reconstruct this very specific antibody structure to fight what it's seen before. The problem with vaccines, though, is they take years to develop. People say, well, why can't you just get some dead virus and inject it into people? I mean, let's just do it. Let's save people. Well, there's multiple problems with that. The testing process is somewhat lengthy. You need to test viruses first in animals, and I know you probably can't read this, but it starts by animal checking just to make sure that you're not killing animals when you inject this virus into people. Then there's phase 1 studies where you take a bunch of volunteers and you're really looking for side effects of that particular vaccine. And then you go on to phase 2 and phase 3 trials, and I won't go into all of that, but the point is it's a very lengthy process. Some viruses or some vaccines, when you inject them into people, actually are very, very effective at producing those antibodies that we talked about. So you say, well, what's the problem with that? Well, some vaccines induce also an effect that actually starts attacking other parts of the body. And that's just one particular example. It'll kill the virus, but it may start attacking and destroying somebody's lung. So these things have to be done very, very carefully. You can't just start being cavalier with this because we're having a epidemic of a particular virus. So the bullet point is this is probably what's going to help us 2 years, maybe 3 years from now, but this is nothing that's going to help probably in the next 12 months. Treatments. So this was kind of fun. The more things change. You just be careful of the advertisement. This is from the 1918 Spanish flu, and this is from a couple newspapers back in 1918. This is from the San Jose News, and this is advertising a guaranteed cure for the Spanish influenza, Boyer's Massage Parlor. Here is another ad. For the influenza, Horlick's malted milk, very nutritious and digestible. It is endorsed by physicians everywhere. Others are just imitations. They did have some things right though back in 1918, and this is about hand washing. This is a soap commercial about hand washing. You need to hand wash before eating, when you come home from work, and whenever you come in from the street, and you must wash properly. And they advertise how it's going to help you not get Spanish influenza. Of course, they did take their opportunity to kind of throw their little twist in there. The healthy odor of Lifebuoy soap is found in no other soap. And we know that soap is soap, and as long as you're doing it correctly, it will work. So here's an example. So we hear about these treatments. Why don't we just give everybody the treatment? Why don't we just give everyone hydroxychloroquine? It might work. So what's the harm? Well, I just want to start with just an example from 2009. 2009 was the swine flu, and it was a very bad flu year. It was the H1N1 that we all remember, and there was this magic drug that came out called Tamiflu. And they had this great marketing campaign. There's no such thing as a little flu. FDA approved down to 2 weeks of age and older. Call your doctor within 48 hours and get this life-saving Tamiflu. I'll be honest. It suckered doctors. I think every doctor had their own stash of Tamiflu sitting in their cabinet, ready to save them when this swine flu hit them. Well, years later, kind of looking back at Tamiflu, they call it Tamiflu fiasco in lessons learned. There were serious side effects. Serious events were reported during the post-marketing surveillance from several countries, although most of the published articles didn't report these side effects. The Tamiflu claims, were it reduced illness by duration by 30%. It reduced severity 40%, reduced all kinds of complications like pneumonia, hospitalization, blah, 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 all of that. But in practice, Japan noticed a bunch of abnormal behavior and disturbance of consciousness. A lot of kids were hallucinating. In Britain, they indicated the likely benefits did not outweigh the risks. Cochrane review did a very large review of Tamiflu, and they did note that there may have been alleviation of symptoms about 24 hours sooner in some people that were healthy, but there was no benefit in asthma, no reduction in pneumonia or hospitalization, and it had severe side effects, had hepatitis, cardiac events, serious skin reactions like Stevens-Johnson, which is a sloughing of skin, renal events or neuropsychiatric events, including suicidal ideation, seizures, and encephalitis. And with all of this, 18 billion with a B, $billion went to the makers of Tamiflu. So my point in saying all this is the conclusion. It's a cocktail of pandemic panic, publicity propaganda, and scientific misconduct turned this new medicine with only modest, if any, efficacy into a blockbuster medicine. So what I'm saying is we just don't want to get involved in the hype of some of these drugs without properly testing them. So let's talk about chloroquine, similar drug, hydroxychloroquine. We've all heard about it's Plaquenil. It's used for some people with arthritis of different types. First of all, it may not work. Now, there's reason to think it might work. It works well against parasites. And how does it work against parasites? It interferes with the parasite, specifically malaria's ability to attack hemoglobin. So it has something to do with hemoglobin interaction, which is the oxygen-carrying component in red cells. Viruses, also, we have known that chloroquine and hydroxychloroquine in Petri dishes have had good antiviral effects. So if you have some virus in a Petri dish and you throw hydroxychloroquine on top of it, I'm being a little figurative here, I'm not the immunologist here, but you can kill it in a Petri dish. However, and so this is the evidence. Chloroquine analogs have been shown to inhibit the acidification of endosomes, blah, 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 and a bunch of medical reasons why it might work. So there's reason to think, well, it works in Petri dish, it might work. There's also reason to think it may work because in the novel coronavirus, this particular, you don't need to read all of this stuff, but the point is what this article is saying is that hydroxychloroquine can interfere with this, with COVID's ability to bind hemoglobin, which we think is one of the things that coronavirus does to harm us. So again, in a Petri dish, we think there's reason to believe that it might work. However, go to studies in the Chinese literature, they're very mixed. There's some studies that are positive, like this one over here. There's some studies that show no difference, like this study over here. These are both very small studies. This study over here, 62 patients, a study that showed no difference. I think it was either 30 to 40 patients. In the French literature, same thing. Some studies are positive, some studies are negative. You say, well, if one's positive and one doesn't show anything, doesn't that mean, well, shouldn't we try it? It sounds like a good drug. Well, the devil's in the details. If you really plow down into this data of what happened here, this was not a randomized trial. What they did was they looked at people and they enrolled them into this hydroxychloroquine study. In the first 26 people that met criteria for the study, they said, okay, you're the group that we're going to study. And by the way, all the people that didn't meet criteria for the study, you're now our control group. So failure number one is it's not randomized. I mean, the people that met the criteria were in, and everybody else, they just said, well, you don't really meet criteria for the study, so we'll just use you as the control. The other thing that they did is of the 26 people that were in, 6 of those people were then excluded from the analysis because 3 did very poorly and went to the ICU. 1 died, 1 stopped because of side effect, and 1 left the hospital and was left to follow up. So of this data, this black line up here is people that did not take hydroxychloroquine. The blue and green lines are both people that took hydroxychloroquine. So it's like, oh, these people shed virus. This is, I think, percentage of viral particles over here. So these people did better than those people, right? There's a pretty graph, and voila, this medicine works. But it's not a controlled study, and these have patients excluded from this data. So very poor study that's been criticized many times over. And then another study that tried to reproduce this over here did not show the same endpoint. That all being said, it may work. We don't know. We need to study it. Now, Khalil is a leading doctor who's actually going to run the first experimental treatment study for COVID-19 by an NIH-sponsored study. And what he said, and he's talking specifically about these hydroxychloroquine studies, without a control group, we can never, ever safely find new medicines for any disease. for example, if a patient dies, it's assumed that he died because of the disease. But if the patient survives, it's assumed that, hydroxychloroquine works, and it is definitely the reason that they lived. But without a control group, it's just not a proper study. Dr. Luciano Borio, who's actually worked for both Trump and as well as Obama, has actually made the comment that hydroxychloroquine has been around for a while. We've known about its antiviral effects, but despite the evidence that suggests activity against viruses in the past, it's never been shown to have success in randomized clinical trials. Now, again, I'm not trying to say that hydroxychloroquine may not be our answer, but we have to temper it with this information. Definitely side effects. That's another reason you don't just kind of blindly give it to people. I kind of stuck this slide's completely in the wrong place. This is a slide for later. The side effects. There's serious side effects of chloroquine. You can just kind of read them over here. We know about the guy. This is a very sad case. The man and his wife, read about the benefits of chloroquine, and they took it. It was an ingredient of their fish tank cleaning additive, and he thought it would keep him from getting COVID, and they both died. Very sad case. Hydroxychloroquine may interfere with other medications, and there's a whole list of medications that it can interfere with and cause cardiac arrhythmias and other problems. There's also fatal toxicity of chloroquine and hydroxychloroquine with metformin as tested in mice. So it can have a serious reaction with metformin, which is extremely common diabetes medicine. There's also this idea of resistance. If you just give hydroxychloroquine to everybody, then the virus actually can figure out how to kind of thwart the effects of chloroquine and hydroxychloroquine. So you don't want to just kind of blanketly give medicines out to everybody for that reason. So they are going to test some other drugs. There are 4 major trials in the United States that are going to be tried. One is with hydroxychloroquine. One is remdesivir, which is an antiviral. And then there's 2 HIV medicines, both with and without another medicine called interferon, that are going to be tried. So these are 4 large case-controlled clinical trials that are going to give us answers to these medicines. What's another therapy out there? There's y'all may have heard of convalescent plasma or hyperimmune globulin. This is where you actually take somebody, this red person. This is someone who is infected with COVID, but now they've recovered from COVID. So they have all these antibodies in their system. So what you do is you take the plasma, the kind of the white or clear part of the blood out of their system. This is what plasma looks like when it's taken out and spun down. You take it out. You get the virus-neutralizing antibodies, which is hyperimmune globulin. It's kind of concentrated plasma. I guess you can think of it in that way. And you can either give it to someone as prophylaxis. We probably won't do it this way, but we can give it to therapy for people that are very, very sick. There's reason to believe this will work. This is Nobel Prize-winning bacteriologist Emil Adolf von Behring, who was the first person to win the Nobel Prize in Physiology and Medicine in 1901. And he did it by using convalescent plasma in treating diphtheria. So diphtheria, there was no antibiotics back at that time, but he knew that there were people that had recovered from diphtheria, and he took their plasma and injected it into people with diphtheria and saved a lot of lives. This exact same method was used to cut the fatality rate of Spanish flu in folks in 1918, and it was also used in the Korean War with what was it? It was actually a type of hantavirus known as Korean hemorrhagic fever that saved Korean troops. We use forms of this actually today with snake bites, using snake bite hyperimmune globulin, and we use it for rabies as well. So this kind of concept has been around for various uses in other realms as well. So convalescent plasma, it's worked well in a pilot study here. It could potentially improve clinical outcomes. This was kind of a safety study they did. And this is a study of that's pretty well known of 5 critically ill patients with COVID-19. This is in China that were given convalescent plasma and made very good recoveries. I think 1 person remained very sick at the time of the writing of this article, but 4 had recovered And these were people that were on ventilators that were not expected to make it otherwise. This is some thank yous that we've had outside of a particular hospital. A number of signs people had made for us. We really appreciate that. This is a sign or a picture that was taken by one of our, in front of one of our PA's houses. All of her neighbors lined up and had these just great signs, and we really are appreciative of these. This is Maddie over here. I don't know Maddie's last name, but it was a nice thank you note to all the doctors and nurses. And I'm going to go ahead and extend that. In Maddie's, I suppose, 5 or 6 years old and probably doesn't know, but there's radiology techs, phlebotomists, there's the patient access team, there's environmental services, respiratory therapists, security, dietitians, clinical support staff. There are a number of people keeping our hospitals going right now, not just doctors and nurses, and a huge shout out to all of those people. And so Maddie made some goodies or some yummy treats for all of us. Thank you very much, Maddie. So this is the last slide. It's just things I want you to remember. This is where we're at in Atlanta right here. Our cases are still going up. They look like they may be kind of tailing off, maybe a little bit, kind of fingers crossed on that one. We're behind other cities. We're doing better. Our cases are not accelerating as fast as some of these others that are now overwhelmed. But we need to keep up the pressure, or we need to keep up the effort. We're doing a great job right now. I mean, people are taking this physical distancing seriously, and we appreciate it at the hospital level. And I know that all of our colleagues at other hospitals appreciate it as well, because we'll lick this thing, but we can't give up, and we need to keep being diligent and paying attention. So that's it. I think we have a number of questions kind of written down. I know Ed's been kind of feverishly writing over here. I'm going to turn this around here. There we go.
So I think the first question, we've kind of alluded to it, but the physical distancing is not just prolonging or postponing the inevitable. It is fewer people will get the disease in our area and all over the world if you physically distance, because I mean, this coronavirus, like a lot of viruses, have these cycles, and it'll run through its cycle, and the next time it comes around, hopefully we are smarter and maybe have more drugs or vaccines to treat it. And it does help by not having that spike and not overwhelming the hospital. But so
I think one thing we touched on is what's the end point to this thing. So in Georgia, the curve goes down. Less people are dying. The hospitals are now clear. So we all go back out on the street, and what's to keep us all from kind of recatching the coronavirus? And I think it's really a great question. And one thing right now we're coming up with, and they have, is a test to see who has actually been exposed. So there are people that have had colds that they don't know is coronavirus or not, because they weren't able to be tested because they were well enough to go home, and maybe they had it, maybe they didn't. What the real answer would be is if we could test everybody in Atlanta, or at least even a representative sample of people in Atlanta or Alpharetta or whatever area we're in, and see how many people have it. I mean, if 80% of the population have actually been exposed to this thing that we just don't know about, then we know that it is probably safe to just kind of let people go. If a very, very few number of people have been exposed, and that just raises a whole other host of questions about how do we kind of get back to our daily lives. And I don't think anyone has a great answer to that. But if we don't know, if we flat don't know how many people out there have it, then we're just shooting in the dark. We have no answer.
I guess we'll find out from China as they've opened up and loosened some of their restrictions. One of the we talked about the testing. We still don't think testing is that important for any one individual as to whether or not you have it, because it shouldn't really change your behavior. If you got a fever, if you don't feel well, you should be even more careful. But I do think we're getting more tests. I think in the next week or so, it's going to get easier to be tested. Going back to what we were just talking about, can people get reinfected? It's kind of too early to know. I don't think so. I think If you do get reinfected, it's a rare thing because once you develop immunity to it, if you have a normal immune system, you're going to be okay. People asking an age-old question about fever. Does that help?
That's a great question. So fever, do we know if fever helps kill the virus, and when should I take a fever reducer? And that's a tough one. I don't think there's really been a great study on that. We do know that fever, when things are warmer, viruses do not do as well. And there's a reason why our bodies produce temperature. It elevates the temperature because the virus doesn't like that. And so it's our body's way of helping eliminate the virus's ability to replicate. So then the question becomes, well, why are we taking Motrin and Tylenol? And the answer is really just to make us feel better. When people feel terrible and they can't eat or drink and they get dehydrated or something, then that's not good either. So there's kind of probably a happy medium in between. I did know a pediatrician one time that said no one should ever take Tylenol or Motrin. And I'm not sure if he ever had children, but I'm not sure that that's the right answer either.
Yeah, so, I don't think it matters a whole lot. I don't think it really matters. Take your Tylenol if you feel better and you can drink more, and I just don't think it matters a lot.
There's a lot been written about whether we should be taking Motrin or Tylenol, that somehow Motrin may be a problem, and I think that's kind of been largely debunked. I think that Tylenol is probably and Motrin are probably equally effective. Whatever tends to work better in you.
I did want to touch a little bit just on how we're doing here in this North Atlanta area. I think inside the perimeter it's been hit a little bit harder than us, at least on the north side of the perimeter. But we're still doing okay. We have some space in our ICUs and we have some ventilators. But that can change really quickly. Doesn't take much. So
that's a question we've been getting a lot of, and that's a great question. So what's going on at the hospital? So if I was to walk in the hospital, what do we see today? And the answer is very different in New York than it is here in Atlanta and a lot of places around the country. A lot of places around the country, ERs are very unbusy right now. Now, that's not true of New York and New Orleans. Their ERs are very, very busy. But right now, people are tending to stay at home and not even going to the hospital. Now, what's happened in the units, though, is the intensive care units are kind of slowly starting to fill up. And certain hospitals, less so, certain more so. In town, more so. Places that have a very high prevalence of this illness, more so. So you're starting to fill up the hospital with those folks. Now, the hospitals have been pretty much emptied out, if you will, at the beginning of this because all elective surgery was canceled. Pretty much anything that was elective was kind of called off. And why did hospitals do that? They were very smart. They did that to allow for an influx of patients when this COVID thing hits.
Because ventilators are used for elective surgeries, and if we need all available ventilators, we don't want one being used for an elective surgery. And also the physical distancing is just helping with just your other diseases too. There's less flu, there's less GI bugs being spread. It's affecting everything, and the decreased workers and everything's affecting the traffic and less accidents. And so I've talked to colleagues in Seattle. I've talked to some colleagues of mine in San Francisco. I have not talked to any colleagues in Detroit where things seem to be getting pretty bad right now. But even in Seattle, a place that was hit very, very hard, their hospital is filling up with patients. But again, their ERs are not full. Their ERs are not backed up. They didn't hit that tipping point that they've seen in New Orleans and New York yet. And in fact, their cases are starting to kind of just kind of level off in these areas. So, I think, in Seattle and in San Francisco, maybe a little early, but they may have kind of successfully flattened the curve in those areas. And hopefully us here in Atlanta will see the same thing. The next question I think is important for a big general term. So somebody's asking about having to stand in line, that they're having to stand in line for a long time. And they do have them spaced 6 feet apart, but this person's worried that waiting in line for 30 minutes, is this safe, and this new guideline. And I think the point is that you can't 100% avoid the risk of getting the disease unless you go out completely by yourself in like a hermit. So standing 6 feet apart, though, is better than standing close to somebody. And if these people are wearing masks, that's better than people not wearing masks. So I really encourage people, if you're going to the grocery store, to bring a mask, because when you're standing in line, you're not going to be breathing on people. You're not going to be breathing on the products in the store. So, yeah, and just the things we've heard about are, people changing their clothes when they come home from work. If you work in a job that you're exposed to people, and washing those quickly, not taking them all over the house, and wiping off the commonly used surfaces, the steering wheel, the main handle coming in your door. These are, these are common things people are doing. It's hard to clean everything all the time, though, but these are the big issues people are discussing. Even us wearing the mask this time, we're getting better at it.
Another question, any repercussions from reduced oxygen through wearing a mask? The masks are very breathable. They don't really reduce your oxygen, your pulse oximetry reading. So safe to wear. Any other questions? We're just kind of thumbing through here. We're coming up on an hour.
You know what? I think, you've checked the bottom. Yeah,
we got a bunch. We got some. Do we have any others that we wrote down? We wanted to hit.
That was. I think that's hitting the main. Haven't disrupted our hospital yet. The hospital is making plans to. I think all the hospitals around here do have surge plans in case things get bad. And remember about the mask, doesn't have to be, grab anything to just cover your nose and mouth.
Yeah.
Bandana.
Well, I think it's about it. We're coming up on about an hour. We appreciate everybody's time. If you have any questions, just you can ask me on Facebook, and I can try to get to everybody. I tried my best to get to as many people as possible last time around. It's kind of hard to scroll up on an iPhone, which Ed's trying to do to read questions. Should we wear a mask while running outdoors? Good question. No, you don't. No. If you're outside, you're much safer. Things disperse very quickly outside. So yeah, you could probably. Maybe that's where that other question came from. I know that person that asked that question was a runner. So yeah, you don't need to wear one while you're running if you're outside. No.
And from Terry, she's asking the main side effects besides fever and coughs. The other, I think the effect on the lungs. It just reduces the people who get it bad, their lungs can't function properly, and so you can't get oxygen to your blood, and then there's some evidence that it can affect your heart later on as the disease advances more. But those are the late effects that kill you. Early on, I think some diarrhea and lack of smell are also the other symptoms.
Oh, there's two more good questions here that just came up that I want to address. One is, do we as athletes have any special ability to weather the side effects of this thing? Okay, speak for yourself. I've become an unathlete, just kind of glued to my computer all day, kind of not doing well with my workout plan. But certainly people with higher constitution that are in good shape, we know just tend to weather illness better than others. And I'm not an HR person, but this is an excellent question about how do I get my medical bills paid for. Went to the ER thinking she may have had COVID, but they didn't test her. I'm making a little permutation of that question, but they may not have tested her, so it's not definitely COVID. We don't know. I think the government was very clear about this, that anyone who goes to a ER or to a doctor or urgent care with the intent to be evaluated for COVID would be covered by insurance. And so insurance plans are required to pay for that. There's also, I think Trump actually came out and said, again, I'm not an HR person here, but said that for for uninsured people, coronavirus testing would be covered as well. Now, I know there's a lot of people listening to that, and again, this is just what I heard. I am not making a statement, trying to speak for anything legal at all, but please look into that, because my understanding is that whether you have insurance or not, these evaluations shall be covered.
So the answer to your question is yes, it should be covered. If she thought she had it, that's why she was being evaluated, she should.
Yes. All right, well, we'll try to sign off a little bit better than we did last time. I think we tried to hit the button, and it took like 3 or 4 minutes, and we had a lot of interesting comments about that.
Ken, I just want to say one last thing.
Oh, sure, far away.
It's saying, for those of us who want to do something, what is the best way for us to show support or provide assistance to hospital? And, I tell you, I mean, we love the support of the hospital. We've been supported. I would say reach out, look around to local charities, communities such as North Fulton Charities, or anybody who's helping maybe the food insecure, because I think they probably need it worse than the hospital staff. We have a cafeteria that's open, and we can get food. I would say please pass it on to some of the charities. I think right now they could use a lot of our support.
Yeah, and along those lines too, just support your local restaurants and everybody that are trying to stay open right now. I know that they're doing very, very good effort to try to keep clean and make sure that their employees are all healthy and that they're not.
The ones I've been to they've got great protocols where you don't have to touch anything. They bring the food out to you. You don't even go inside. Some of them, I mean, they put some good thought into this to really reducing the risk.
Yeah, it's really great excuse to eat out like every night.
Exactly. Well,
I don't all right, we'll leave that alone. But we definitely want to help our local community. So think about all your neighbors and so on that may be struggling right now. So, all right, thanks everyone, and be safe and continue to practice physical distancing. I think we're doing a great job. We're on the steep part of this curve right now. Right now is the time to kind of knuckle down, double down, if you will, and let's lick this thing. Thanks, everyone.
Thank you.